High gas prices, housing and utility costs, food inflation, and fears of an economic downturn all top the list and give working Americans a real concern about their economic insecurity. With costs for everything rising under the policies of the Biden-Harris administration, it's important for Congress to look at ways to lower costs for American families. With constituent concerns top of mind, we meet today to discuss the bedrock law that helps provide economic security, stability, and protection to a majority of the people we serve because it protects employee benefits. Specifically, we will discuss the value of employer-sponsored health care benefits under the Employment Retirement Income Security Act of 1974, or ERISA. In the 50 years that ERISA has been the law of the land, it has helped incentivize employers to offer health care benefits that cover over 153 million Americans, or roughly half the population. ERISA works because of its preemption clause. As a conservative, you won't often hear me say I support federal preemption of state law, but in this instance, ERISA's effect is to alleviate the burden of government on employers, which actually helps workers. Without ERISA preemption of state law, the patchwork of state regulations would hamper a business's ability to offer uniform coverage options. Imagine being relocated within the same company to a different state, that happened to me several times, and having to navigate an entire new system of healthcare regulations. Thanks to ERISA, we can avoid that disaster. Employers can simply comply with the protections outlined in ERISA and provide health care to employees around the country. According to a Society for Human Resources Management survey, 90% of workers consider health care to be an extremely important or very important benefit. Another survey by Protecting Americans Coverage Together found that 93% of Americans are satisfied with their employer-sponsored coverage. With stats like that, it seems hard to believe that there are politicians who want to dismantle ERISA in favor of government-run health care. But private health insurance is at risk due to the push of the left for Medicare for all. The Biden-Harris administration wants to make private health care unaffordable and unattainable so that Americans think they have no choice but to support government-run plans. They have saddled employer-sponsored health care with more regulations and have removed viable coverage options like association health plans and short-term limited duration plans. The Democrats' misnamed Inflation Reduction Act shifted billions of Medicare dollars to fund failing Obamacare plans. Now Democrats plan to extend expanded premium tax credits beyond 2025 at a cost of $335 billion. I don't think they understand that using tax dollars to pay for certain Americans' monthly health care costs is robbing Peter to pay Paul and actually makes health care less affordable for everyone. It costs the government over $1,000 more per patient per year to place someone on an Obamacare plan than on an employer-sponsored insurance plan. Beyond Obamacare, the proposals from this administration and Democrat nominee Kamala Harris are somehow even more radical. Vice President Harris has explicitly endorsed Medicare for All, a plan which calls for the elimination of private health insurance. This would prevent over half of America from keeping the plans they have now and that they overwhelmingly prefer. A single-payer system would mark the end of ERISA as we know it and cost taxpayers an estimated $32 trillion. Worse, her plan provides taxpayer-funded health care for illegal immigrants. If the government has any legitimate responsibility in health care, it should at least be to benefit its own citizens. Before I close, I want to take a moment to play a video from the Washington Post that highlights just how real this threat to ERISA is.
I intend to co-sponsor the Medicaid for All bill. And because it's just the right thing to do. I'm proud to co-sponsor it. It is about saying that this is about a right, not about a privilege for a few. You don't have to go through the process of going through an insurance company. Let's eliminate all of that.
Medicare for All would effectively eliminate private insurance. It would essentially phase out private insurance companies
as the main source, but there would still be supplemental. There'd still be access to supplemental.
Okay.
It was in the context of saying, let's get rid of all the bureaucracy. Let's get all of the ways.
Oh, not the insurance companies.
No, that's not what I meant. I support Medicare for All. It is my preferred
as a principle, you mean, not Bernie Sanders' bill?
I support the bill.
Okay.
I support the bill.
Well, because the bill gets rid of private insurance for everything
It doesn't get rid of supplemental insurance.
Right, for cosmetic surgery, but for all...
Mr. Chairman, point of order, please.
Who here would abolish their private health insurance in favor of a government-run plan? All right.
Do you believe that private insurance should be eliminated in this country?
No.
You don't?
No, I do
not. But
not.
you raised your hand last night.
But the question was, would you give up your private insurance for that option? And I said yes.
My plan will separate your health care
Mr.
from your
Chairman, point of
employer.
order, please.
Meaning your employer will no longer
Pardon?
dictate the kind of health care you receive. Under my plan of Medicare for All, private insurance companies will be able to provide coverage if they play by our rules.
Thank you to our staff. It's interesting, we just had the Vice President, in her own words, without any commentary, and for some reason, some members didn't want anybody to hear that. It's very interesting.
Okay.
She says...
Point of order,
she
please.
The gentleman's not recognized. She says, under my plan of Medicare for All, private insurance companies will be able to provide coverage if they play by our rules. Although she tries to moderate and disguise her position by acting like private insurance companies can keep functioning as normal, does anyone really think they will get better health care when they're playing by Kamala Harris's rules? The Democrat plan is to make private health care unaffordable and ultimately non-existent. One way to do this is to provide artificially and temporarily lower cost government-provided health care to drive private providers out of the market. But everything the government does ultimately costs more, especially with the initial cost of the exploding debt that causes higher taxes and higher inflation. Every government expenditure either causes higher taxes, higher inflation, or debt exploding for the taxpayer. At a time when many Americans are living paycheck to paycheck and personal savings rates are near historic lows, rising health care costs are driven by government interventions are unmanageable. Permitting ERISA plans room to expand and innovate is the solution. Now it's time for Congress to work to strengthen ERISA and employer-sponsored health benefits for the next 50 years and beyond. With that, I now yield to the ranking member for his opening statement.
Just a question for the point of order. Is that question the relevance of the video in particular? It's more of a political statement. And I know that there's some license here in Congress for that, but that was extreme in the 10 years I've been here in Congress. Mr. Chairman, it's unfortunate. There is work we could do with ERISA, clearly, but being as partisan as you just introduced this and using absolutes about every time there's a tax increase, every time the government spends money, it leads to all of these horrible things. This is a mixed market economy, a capitalistic economy, and it requires rules and guidance that we all come to agreement on to make it work, including, unfortunately, some of the worst aspects of human nature's greed and the lack of ethics. And we're going to talk about that a little bit today, for instance, with MultiPlan. So in the spirit I think we've had for the last 4 years when we've been on this committee, I appreciate our differences, but that was a rather extreme opening comment in my perspective. To the witnesses, thank you for being here. All of your perspectives are valuable, and we appreciate it, this important hearing on ERISA. When ERISA was enacted in 1974, Congress made its intent clear. The law's primary purpose is to, quote, protect the interest of participants in employee benefit plans and their beneficiaries, end quote. To that end, ERISA established crucial consumer protection standards, provided remedies to workers whose claims are denied or whose plans are mismanaged, and required fiduciaries to act solely in the best interest of the plan participants. As our subcommittee discusses ERISA today, it's vital to keep this fundamental purpose at the forefront. It's about consumers. We must also keep in mind the urgent need to improve the efficiency of our healthcare system. Our country currently spends more than 17% of our gross domestic product, over $4.5 trillion, on healthcare, far more than our peer countries. Workers and consumers are increasingly shouldering their costs through rising premiums and deductibles. Yet our health outcomes are among the worst in the developed world. In the other developed countries, they have a form of universal health care, so everyone can get quality health care. Different versions in different countries allow for the private sector to participate in it. They have better outcomes, longer lifespans. The healthcare system is plagued by numerous challenges and inefficiencies, including, excuse me, the lack of price transparency, the excessive fees charged by self-dealing third-party administrators and pharmacy benefit managers, and the escalating cost of medical care and prescription drugs. As the New York Times has documented, companies like Multiplan and major third-party administrators make huge profits by charging high fees to employers, shortchanging healthcare providers, and leaving workers on the hook for exorbitant medical bills. And yes, frequently their actions lead to death. This is not an efficient use of our healthcare dollars, which is why Ranking Member Scott and I have written to the Department of Labor in support of their oversight on these practices and more funding for them so they can do a reasonable job. I sincerely hope my Republican colleagues will consider joining us to address these issues, including by supporting adequate funding for the vastly under-resourced Employee Benefit Security Administration and extending the bipartisan No Surprises Act implementation fund, which expires at the end of the year. Despite the challenges we continue to face, it is also important to acknowledge the significant progress we've made in recent years. The Affordable Care Act has provided preventative health services at no cost, protected tens of millions of Americans with pre-existing conditions, and allowing young people to remain on their parents' health plans until they turn 26. And the American Rescue Plan Act and the Inflation Reduction Act strengthen ACA premium tax credits. The tax credits reduced monthly costs for low-income individuals and provided premium relief to millions affected by the subsidy cliff. Particularly self-employed small business people, and just yesterday, the Biden-Harris administration finalized landmark new rules that will benefit compliance with the Mental Health Parity and Addiction Equality Act and ensure that behavioral health needs are treated fairly by insurers and in health plans. While these reforms have strengthened workers' benefits and improved the efficiency of our healthcare system, I am concerned by the proposals to take us backwards. For instance, one of our biggest recent successes in that Biden-Harris administration, for the first time, recently completed negotiations under the Inflation Reduction Act to reduce drug prices for nearly 9 million Medicare beneficiaries, while slashing seniors' out-of-pocket costs by $1.5 billion in 2026 alone. Yet despite these historic savings, the Republicans' extreme Project 2025 policy agenda proposes to repeal this program and instead put billions in the pocket of Big Pharma. I am a recipient of one of those 10 drugs. When I first got it to save me from stage 4 cancer, it cost as much as $500 a day. Now, thanks to this and the pressure we put on them, it's closer to what the European Union charges of under $90 a day. In Australia, it costs $37 a day. American taxpayers are subsidizing lower cost in other developed countries. Rather than roll back our historic progress, this committee should move forward with House Democrats' legislation to extend drug price negotiations beyond Medicare and save billions for workers and businesses with private health insurance. While we may not agree on every issue, I hope that today will be a robust discussion on the future of employer-sponsored coverage and how we can collaborate across the aisle to address the challenges we face and get rid of the inefficiencies and the greedy profit-taking by some private sector entities. I yield back.
Pursuant to Committee Rule 8C, all members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5:00 p.m., 14 days after the date of this hearing, which is September 24, 2024. Without objection, the hearing record will remain open for 14 days to allow such statements and other extraneous materials referenced during the hearing to submitted for the official hearing record. I note for the subcommittee that some of our colleagues who are not permanent members of this subcommittee may be waiving on for the purpose of today's hearing. I will now turn to the introduction of our distinguished witnesses. Our first witness is Ms. Elise Schuman, who is Senior Vice President for Health and Paid Leave Policy at the American Benefits Council in Washington, D.C. Welcome, Ms. Schuman. Our next witness is Ms. Holly Wade, who's the Executive Director of the National Federation of Independent Businesses Research Center in Washington. Welcome, Ms. Wade. Our third witness is Mr. Anthony Wright, who's the Executive Director of Families USA in Washington, D.C. Welcome, Mr. Wright. And our final witness is Dr. Paul Froston, who's the Director of Health Benefits Research for the Employee Benefit Research Institute, EBRI, am I saying that right? EBRI? In Washington as well. Thank you, Dr. Froston. We thank the witnesses for being here today, and we look forward to your testimony. Pursuant to committee rules, I would ask that you limit your oral presentation to a 5-minute summary of your written statement. And I'd also like to remind the witnesses to be aware of their responsibility to provide accurate information to this subcommittee. And we'll now recognize Ms. Schuman for 5 minutes.
Chair Good, Ranking Member DeSaulnier, and distinguished subcommittee members, thank you for the opportunity to testify on behalf of the American Benefits Council. Employers play a critical role in the healthcare system, providing health benefits to nearly 180 million Americans. In sponsoring these benefits, employers have made significant contributions not only to the health and well-being of working families, but to taxpayers, the economy, and the healthcare system as a whole. For 50 years, ERISA, and ERISA preemption specifically, has been the cornerstone of employer-sponsored health benefits. America's employers recognize that their investment in health coverage is an investment in their workforce and in their business success. And working families and voters recognize its value too. According to polling data from the Winston Group on behalf of the Alliance to Fight for Healthcare, more than 3/4 of registered voters expressed satisfaction with their employer-sponsored health coverage, far preferring it to a stipend to shop in the individual market, and an even more stark preference over a system where employers do not provide health benefits at all. Employer-sponsored health benefits yield a significant return on investment to the federal government and taxpayers. For every dollar of federal expenditure for the tax exclusion of employer-sponsored health benefits, employers pay more than $5 in benefits. It would cost taxpayers substantially more to provide the same level of health benefits through a direct government program. With a vested interest in securing the health and well-being of their employees, far from being mere payers that just sign checks for health benefits, our member company employers have been innovators in market-driven approaches to provide high-value benefits. Our member companies also clearly understand that their innovation and ability to provide affordable, high-quality health coverage are built on the foundation of ERISA by enabling self-funded multi-state employers to offer uniform benefits to their employees nationwide. However, ERISA preemption is under assault as states seek to impose their own requirements on self-funded group health plans. Without ERISA uniformity, these plans would be extraordinarily difficult to administer, forcing employers to offer different benefits to their employees based on their location. ERISA's 50th anniversary comes at a critical time to convey this important message. I also want to stress that employers are deeply concerned about overly burdensome federal health plan regulations that add cost and complexity, but without commensurate value to either plan sponsors or employees. I also want to stress that employers are deeply concerned about rising healthcare costs, fueled by a lack of transparency and competition. While employers continue their innovative efforts to lower costs, federal legislative solutions are needed to create a more competitive and transparent healthcare marketplace. 90% of voters with employer-sponsored coverage agree that it's important for Congress to take action this year to lower healthcare costs, and there are solutions at hand. The Council strongly supports the lower costs, more transparency, including its PBM provisions. And more than 80% of voters agree that it should be a priority for Congress to pass price transparency legislation. The Healthy Competition for Better Care Act. It's critical that with growing market power, large hospital systems are able to demand higher and higher prices and impose anti-competitive contracting restrictions that stifle competition. The Council urges the committee to pass the Healthy Competition for Better Care Act. Allowing hospital facility fees to be charged for telehealth appointments is precisely the type of payment distortion and obtuse billing practice that increases costs for patients and payers. Voters agree by an overwhelming margin of 8-1 that patients should not be charged for this. The Council urges the committee to approve the Transparent Telehealth Bills Act to address this concern. On this 50th anniversary of ERISA, the message is strong and clear from employers, employees, and voters about the significant value of employer-sponsored health coverage that is built on its foundation. So is their call for Congress to take action this year to lower health care costs. These steps rely on and must be taken in concert with the uniformity ERISA preemption affords. 50 years after this landmark legislation was enacted, its provisions are even more important today. I appreciate the opportunity to testify.
Thank you. We'll now recognize Ms. Wade for 5 minutes.
Dear Chair Good, Ranking Member DeSaulnier, and distinguished members of the subcommittee, on behalf of NFIB, I appreciate the opportunity to testify. Small businesses are the foundation of the U.S. economy, but unfortunately, in recent years, the small business half of the U.S. economy has been significantly impacted by inflation, along with significant challenges in attracting qualified applicants for open positions. Operating a business in these conditions is particularly difficult for small business owners. Most small business owners compete for talent by offering competitive wages and attractive benefits. Health insurance is one of the most popular but costly benefits offered by about 30% of small employers. However, escalating health insurance costs add to the inflation pressures many business owners face. These higher costs limit their ability to compete in the marketplace. The relationship between small businesses and health insurance has been a long-standing challenge for owners, whether they offer or don't offer the benefit to their employees. 63% of all employers believe that providing health insurance to recruit and retain employees is very or moderately important to them. Almost all, 94% of small employers, find it challenging to some degree to manage the costs of providing employer-sponsored health insurance. The cost of health insurance continues to rank as the most burdensome issue for small business owners, a ranking it's held since 1986. Currently, 41% of small business owners report it as a critical issue in operating their business. The average cost of individual health insurance plan has increased 112% in the last 20 years for small employers. The average deductible for those policies has increased by 194%. Small businesses are not only paying significantly more for their health insurance, but their deductibles are more costly as well. In response to these escalating costs, the offer rate among small businesses has declined from 42% in 2004 to 30% in 2023. The lack of insurance options and affordability issue creates significant headwinds for small business owners in that most of them find the benefit important in retaining current employees and recruiting applicants. Broken down by employers who do and do not currently offer health insurance, 94% of owners who currently offer believe it is important, and 58, over half percent of owners who do not currently provide health insurance find it important in those aspects of retaining and retention of employees. Almost 2/3 of non-offering small employers say that the health insurance is too expensive for them to offer it as a benefit. Most small business owners offering health insurance purchase fully funded plans in the small group market. However, the small group market has experienced a sharp decline in issuer participation and overall membership, down 7.4% from 2022 to 2023, ending the year with 8.5 million participants. This decline is driven primarily by the escalating cost of insurance. The coverage options in this market have declined. Alternatives, like those provided under ERISA framework, become vital. Recent reports point to an increase in the percentage of small firms offering health benefits through a level-funded plan, for instance. As we mark the 50th anniversary of ERISA, it's an opportune time to reflect on the roles that employer-provided coverage has played in the U.S. and on small businesses. While most small firms remain fully insured, ERISA protections have been crucial in ensuring that even the smallest businesses can offer health benefits to their employees while having the flexibility and predictability to design benefits in a way that works best for them. Moving forward, ERISA should be protected and strengthened to empower those small businesses with greater coverage choices under this framework, enabling them to offer valuable benefits that will contribute to their growth, stability, and success in the U.S. economy. Some policy solutions to strengthen small firms' coverage choices: allowing small businesses and self-employed individuals to band together to achieve savings through economies of scale. Protect small businesses' access to stop-loss insurance. Reevaluate and right-size mandates that drive up premium costs. And promote price transparency and price certainty. We thank the committee for its vital work in the past year expanding coverage choices for small businesses under ERISA and look forward to partnering with you to continue building on this law's success. Thank you for allowing me the opportunity to testify for you today.
Thank you. We'll now recognize Mr. Wright for 5 minutes.
Thank you. Good morning, Chairman Good, Ranking Member Scott, Ranking Member DeSaulnier, and members of this committee. My name is Anthony Wright. I serve as the Executive Director of Families USA, a national healthcare consumer advocacy organization. I appreciate the opportunity to testify on behalf of consumers and workers on the 50th anniversary of ERISA, which is an excellent excuse to have some cake, but also to reflect on the employer-sponsored coverage and its state, which is a pillar of our healthcare system that covers 60% of the nation, 164 million Americans, including 2/3 of them in self-insured plans under ERISA. Workers with on-the-job benefits often consider themselves lucky to have group coverage, having a large employer share in the cost of coverage and to negotiate for the best quality and cost. But they increasingly need help to access basic benefits or key consumer protections, and most of all, on affordability. Only Congress can provide that help, since ERISA's broad state preemptions significantly diminish states' ability to innovate and improve healthcare quality, access, and affordability, limiting states from even enacting modest efforts like requirements to contribute to state health payment databases for greater price transparency. Therefore, it's Congress that needs to be vigilant and proactive in updating ERISA and other federal laws to improve health access and affordability. That's why Families USA, over the last many decades, has supported the many congressional actions to improve ERISA, such as COBRA, HIPAA, mental health parity, and the Affordable Care Act. The most recent example is the No Surprises Act, which bans surprise bills. Prior to that, 33 states passed their own protections, but they didn't apply to millions of their residents in self-insured plans. Congress should continue to take steps that supplement state action, whether on the unfinished work on surprise ambulance bills or on filling holes in ERISA standards and patient protections. For example, shouldn't all large employers be required to provide the same essential health benefits that small employers give their workers? Some states are now working to update and improve their essential health benefit standards to better meet consumers' needs. The federal government should follow. Similarly, only Congress can provide relief to those in self-insured plans who need more comprehensive remedies for denials of medically necessary care. And another issue, when consumers have these or other problems, no one knows where to go for help. And I mean no one. While 40% of the nation are in these self-insured plans, in a recent KFF survey, 0% of respondents guessed that their plan was regulated by the Federal Department of Labor. Congress should ensure that the department has the adequate staffing and resources to ensure proper oversight of ERISA plans and their finances, to take complaints, and to support consumer assistance programs to help people navigate our complex healthcare system. Ultimately, the biggest issue for ERISA plans is the biggest issue in all of healthcare: affordability. No one is insulated from high healthcare costs, not even large employers and their workers. Inflated and irrational healthcare prices are putting Americans' health and financial security at risk. More than 100 million Americans are saddled with medical debt. Half of all Americans report foregoing medical care due to cost, and 1/3 of Americans indicate that the cost of medical services interfere with securing basic needs like groceries and rent. Over the past 25 years, the cost of family employer-based plan has increased from $6,500 to almost $24,000. The worker's share of premium and out-of-pocket costs has risen dramatically as well. In 2007, 60% of individuals in employer-based coverage had minimal deductibles under $500. Now 60% have deductibles over $1,000. For most low-wage workers, that means they have to pay more than what they have in the bank before most of their coverage even kicks in. For workers and employers alike, as we see today, rising healthcare costs have become unsustainable. Fortunately, Congress has the opportunity to take action to improve healthcare affordability, including addressing the underlying market failures that drive rising healthcare costs, ensuring price transparency, site-neutral payments, and other reforms advanced by this committee in the Lower Costs, More Transparency Act, broadening the prescription drug cost containment policies in the Inflation Reduction Act into the commercial market so we have more discounts for more drugs for more people, taking timely access to extend enhanced tax credits to prevent dramatic premium spikes if they're allowed to expire next year, and instituting and updating caps on out-of-pocket costs, both for prescription drugs and generally. Thank you again for the opportunity to join in today's discussion on the ways to build on the foundation of ERISA to improve access to affordable coverage to everyone, including workers and their families. I yield back.
Thank you. We'll now recognize Dr. Froston for 5 minutes.
Chairman Good, Ranking Member DeSaulnier, and distinguished members of the subcommittee, my name is Paul Froston. I am the Director of Health Benefits Research at the Employee Benefit Research Institute. Established in 1978, EBRI is committed to data dissemination, policy research, and education on financial security and employee benefits. Consistent with our mission, EBRI does not lobby or advocate specific policy recommendations. Thank you for the opportunity to appear before you today. Employers' commitment to worker health established its roots in the late 1800s. Examples of health programs include the mining, lumbering, and railroad industries. Employers had a practical interest in their workers' health. During World War II, employers began to offer more formal health insurance. Because employer contributions to insurance did not count towards wage controls, health insurance became an attractive means to recruit and retain employees. Employers today offer health coverage because of their belief that offering has a positive impact on the overall success of the business. And ERISA's preemption of state law has created an environment of national uniform standards for employee benefit plans, thus giving employers the regulatory means to continue to offer health benefits as they do today. Yet there have been questions along the way as to whether employers have reached a tipping point with health benefits. Predictions have been made that employers would stop offering coverage. In this testimony, I examine how the availability of employment-based health coverage has been changing. I examine employer sponsorship of coverage, as well as employee eligibility for coverage. There's no comprehensive data set that allows us to go back to the days of ERISA. However, the percentage of the population with employment-based health benefits can be tracked. It was at or near 70% between 1970 and 1989. Between 89 and 2007, it varied between 62 and 68%. Since then, it has varied between 58 and 62% and was 61% in 2022. The declines in coverage often coincided with relatively high increases in premiums, though there were years when the correlation was far from perfect. The more recent stability in premiums coincided with stability in the percentage of the population with employment-based health coverage. In 2022, employment-based health coverage continued to be the most common source of health coverage. When examining data since 1996, the percentage of employers offering health benefits was at a near record low in 2023. However, it is important to put this in context. Small employers are in large part responsible for the decline in coverage, and most employers in the U.S. are small. Just about every employer with 100 or more employees offer health benefits today. Despite the overall decline in the percentage of employers offering health coverage, the percentage of workers eligible for health benefits has been mostly constant since 1996. The eligibility rate has not changed much because the majority of workers are employed by large firms. Workers have historically rated their health coverage as favorable and continue to do so. Just over one-half are extremely or very satisfied with their current plan, and one-third are somewhat satisfied. Only 12% say they are not at all satisfied, and these figures are essentially unchanged since the late 1990s. ERISA effectively preempts state and local regulation of self-funded health benefits. The scope of this has generated some degree of debate. Proponents of ERISA preemption point to the creation of a uniform and predictable regulatory environment for employers, while detractors believe that state and local governments ought to have a greater role in pursuing healthcare reform beyond their current ability to regulate health insurance. On Thursday, EBRI is releasing the findings from a series of focus groups with benefits decision makers at large employers. Three main themes emerge from these discussions. First, under ERISA preemption, there is a uniform landscape of regulations rather than a patchwork of different state-level regulations, which makes it possible for an employer operating in more than one state to administer and offer benefits equitably to their employees. Second, ERISA preemption reduces administrative costs, thus enabling employers to deliver richer benefits and lower cost coverage to their workers. Third, ERISA preemption fosters innovation that would otherwise be stifled by different states requiring different coverages or administrative rules. Employers remain committed to providing health benefits to employees and their families. If ERISA preemption were eroded, however, benefits executives worry about higher costs for providing health benefits. Chairman Good, thank you again for the opportunity to appear before the committee today. My colleagues and I at EBRI look forward to working with you and members of the committee in the future. Thank you.
Thank you. Under Committee Rule 9, we will now question witnesses under the 5-minute rule, and I will wait to ask my questions at the end, and therefore recognize Mr. Wahlberg from Michigan for 5 minutes.
Thank you, Mr. Chairman, and thanks to the panel for being here. The Employer Retirement Income Security Act, ERISA, enacted in 1974, is a cornerstone of American labor law that has profoundly shaped the landscape of employer-sponsored insurances we've all mentioned today. ERISA has played a vital role in elevating the quality of employer-sponsored insurance over the past 50 years. It's empowered workers, retirees, and others to make informed decisions about their health and retirement benefits, ensuring that their needs are met throughout their careers and into retirement. ERISA has not only contributed significantly to the stability and security of millions of working families, but also brings tremendous values to taxpayers and the economy overall. So thank you to the witnesses for being here to help commemorate ERISA's 50th anniversary. Mr. Chairman, I don't see any balloons in the room, but we probably should have had some, though we do have some hot hair, I guess, in the room. Ms. Schuman, thank you for being here. In what key ways has the healthcare industry changed since the passage of ERISA in 1974?
Okay. Thank you, Congressman, for that question. The healthcare industry has changed dramatically in the past 50 years. It's certainly become more complex and consolidated, but it's also become more innovative. And a lot of this innovation has been enabled and fueled by ERISA and the employer innovation that enables and fuels.
Let me jump on that and ask you to suggest some top recommendations that you might give to Congress on how ERISA can continue to protect employers' ability to offer high quality and affordable health benefits.
Well, first of all, let me thank you by recognizing the connection between ERISA and the ability of employers to offer affordable, high-quality coverage. And that's predicated on ERISA and ERISA preemption and the ability to offer affordable, high-quality coverage to their employees nationwide. So my top recommendation for you on how ERISA can continue to protect employers' ability to do so is to protect ERISA preemption, mindful of expanding efforts at the state to erode that. But Congress does need to do more to address the lack of transparency and competition in the healthcare marketplace that are driving higher costs for employer-sponsored coverage. And those two can and must be taken in lockstep, protecting ERISA and ERISA preemption, and at the same time, taking action to lower health care costs. Thank you.
Thank you. Ms. Wade, could you discuss the challenges small employers face when they try to offer coverage to their employees, and what kinds of innovative coverage models would make it easier for small business to offer health coverage, and also if you would comment on how expanding access to association health plans would help small businesses to offer coverage.
Certainly, thank you for the question. For small firms, they are challenged in a whole myriad of ways, one of which is whether they offer health insurance at the beginning of operating their business as an employer firm. The challenge of cost and affordability is impacting their ability to construct competitive packages to attract talent, to retain their current employees. One of the key components for small businesses in the affordability aspect is allowing a diverse array of plans and structures in the benefit to offer their employees that makes sense to them. So more transparency in the cost part of it, but offering more plan designs that make sense for them to offer to their employees. Association health plans, the way it's constructed, is very specific and confined and restricted to a lot of small business owners currently. Expanding the availability of association health plans to a larger population would allow them to purchase in economies of scale that are more afforded by large firms and will give them a competitive leg up from their current status right now in being able to afford. As I mentioned in my statement, those who aren't able to afford health insurance and offering currently are looking to do that. They want to be able to compete for talent and retain current employees. So many of them are hoping that in the future the affordability will be more manageable and that they will be able to offer the benefit to their employees because they know that that is the second most valuable outside of wages for a competitive structure of that.
Thank you. My time has expired. I yield back.
Thank you. We'll now recognize Mr. Courtney from Connecticut for 5 minutes.
Thank you, Mr. Chairman. To the witnesses, Mr. Froston, I think, did a really nice job about, going back to the origins of employer-sponsored insurance, that the World War II decision to make the value of those plans tax-exempt really has been sort of foundational. And again, I would just like to ask all the other witnesses this simple question, yes or no. Do you think Congress should reduce the tax-exempt status of healthcare employer-sponsored health plans?
Absolutely not.
Ms. Wade?
Absolutely not.
Mr. Wright?
Given that it's a foundation for 60% of people to get coverage, no.
And again, the reason, and as a former employer, is that if Congress made that move, it basically would add to the taxable income of all the employees of Ms. Wade's membership as well as Ms. Schulman's membership. Unfortunately, this is a very relevant issue in 2024. Project 2025, which is the document generated by the Heritage Foundation with dozens of former Trump officials, Russell Voigt, the former budget director of the Trump administration, also the chair of the Republican National Committee's Platform Committee. Again, in that package, in Project 2025, it proposes to cap the tax exclusion below 100%, which is a tax increase for workers of employee-based, employer-sponsored plans. The Republican Study Conference, which again is closer to home here in the House, about 70% of the membership of the Majority Caucus issued their 2025 budget document earlier this year, which proposed the same thing. Again, if you look at the history surrounding this issue, Milton Friedman, the godfather of conservative economics, wrote an essay, Mr. Froston's probably familiar with it, How to Fix Healthcare Costs, where he proposed eliminating the tax-exempt status of employer-sponsored insurance. So this year, in 2024, given the fact that we have Project 2025, which again is got the fingerprints of the former president's, former employees as well as people working on his campaign, proposing to cap the tax exclusion, as well as the Republican Study Conference doing exactly the same thing. When we're talking about threats to employer-sponsored insurance in 2024, that's really the elephant in the room in terms of making sure that the foundational cornerstone that created employer-sponsored insurance back during World War II remains intact. And I can say this as somebody who, when we passed the Affordable Care Act, and Ms. Schulman knows this, it included a Cadillac tax, which we furiously were succeeded in terms of delaying the impact of that for 10 years after the law passed. And then finally in the House, with a bill that I was the lead sponsor and had great bipartisan support, stripped that from the law by a vote of 419 to 6. There is strong bipartisan support for maintaining the tax-exempt status of employer-sponsored insurance. However, that is very much at risk in terms of just the positioning of different forces, think tanks and other groups that really want to go at this, which again, if you go back and read the Godfather, Milton Friedman's economic treatises on this, I mean, that is just a fundamental tenet of a lot of conservative economists in this country, which is that that's really the source of a lot of the problems for the cost of healthcare insurance. Mr. Wright, you mentioned the fact that the Inflation Reduction Act last August 15th during the recess announced the first 10 medications in terms of the negotiated prices, 80% cut in cost of some of those very high cost, high utilized medications in Medicare. We have a bill, the Lowering Drug Costs for American Families Act, which would extend the benefits of that negotiation to employer-sponsored plans or individual plans. Optional, don't have to do it if you don't want it. But can you, from Families USA, would that help small employers as well as individuals get the benefit of lower costs, which are driving higher premiums?
The short answer is yes, that individuals, businesses, insurers, other payers are all struggling with the cost of high, inflated, and irrational health prescription drug prices. Using the authority of negotiation that is in the Inflation Reduction Act to extend those discounts not just to the Medicare program but more broadly in the commercial market would be a big boon and start to chip away at the affordability issues that people have at the pharmacy and when paying premiums.
Thank you. I yield back.
Thank you. We'll now recognize Mr. Allen from Georgia for 5 minutes.
Thank you, Mr. Chairman. And first, just quickly, my position on employer health insurance, or ERISA. We're going to always have a government program in this country, but we need to give the business community the flexibility to provide the best coverage at the best value for their employees. The business community will figure this out, and my position is to give this coverage the same waivers that the Affordable Care Act gave to unions and the faith-based part of the healthcare industry, so that we can get totally away from federal regulatory issues dealing with ERISA, as far as compliance and all the cost and everything that's being added to that. And I also want self-employed people to be able to participate in ERISA. We don't have time to discuss that today, but I would like your written response to that idea as far as going forward and how to solve this tremendous cost increase in health insurance. In recent years, another matter is growing adoption of so-called alternative funding programs in employer-sponsored plans. Some stakeholders have suggested that AFP vendors divert employees into their programs and push employers to adopt discriminatory benefit designs that single out medicines that treat specific conditions. It's suggested this type of action could violate ERISA and HIPAA compliance. Representative McBath and I recently sent a letter urging the Department of Labor to investigate the prevalence of AFPs in the employer-sponsored health coverage market and ask the DOL to take action to prevent these predatory practices. Ms. Schuman, how well do you think employers are aware of potential ERISA compliance risks with AFPs? Have you provided any education about compliance risks to member companies?
Thank you for that question, Congressman. The Council's membership typically rely on traditional PBM and drug payment models, so members have not raised AFPs as an issue that I'm aware of, and the council has not actively addressed AFP with its members. It does sound like this is certainly a concerning practice, but I said it hasn't been brought to our attention by our membership. But certainly drug costs are a big concern for our members, and just want to take this opportunity to again offer my support for the great bipartisan work of this committee already in the Lower Cost, More Transparency Act to bring more transparency and oversight of PBMs in an effort to do that.
Well, it's a long and frustrating fight to get your medications approved through the PBM step therapy process. It often results in missed days of work and a worsening of their condition. The lack of transparency, as you mentioned, PBM practices makes it difficult for employers to assess whether the administration of drug benefits aligns with their employees' best interest and well-being. Many people I represent in the Georgia's 12th District experience these same frustrations, which is why I'm proud to co-sponsor the Safe Step Act, which would ensure employer health plans, including their contracted PBMs, offer an expedient and medically reasonable step therapy exceptions. Dr. Froston, how would legislation such as Safe Step Act help people with chronic conditions who are covered by the ERISA plan?
So I haven't studied the Safe Step Act specifically, but it sounds like it would streamline prior authorization process and speed up the process of getting certain medications when other medications are not working as expected.
What can be done to help employers navigate the complex benefit structures, pharmacy networks, and formularies that are obscured by the PBM incentives?
So PBM incentives are complex, and I think building an employee benefit program is complex as well for many employers, even large employers, and sometimes beyond the expertise of many benefit managers. That's why they use consultants. They use ERISA attorneys. They often learn from each other at conferences. There are some purchasing coalitions that employers have joined to help them navigate the complex healthcare system and provide them some leverage.
Good, thank you. I am out of time. I have additional questions I'd like to submit for the record. And with that, I yield back.
Thank you, without objection. Now we'll recognize Ms. Manning from North Carolina for 5 minutes.
Thank you. With regard to the antics at the top of this hearing, I didn't realize we were playing campaign ads here. In fact, I thought there were ethics rules that separate our official acts from campaigning. And if I had known, I certainly would have brought a few campaign ads of my own to play. But I'd like to turn to the actual subject of this hearing. And I want to start by thanking our witnesses for being here to celebrate the anniversary of ERISA. It is the essential cornerstone of our nation's healthcare policy and the consumer protections Congress has passed to strengthen it, such as the Affordable Care Act, have ensured better outcomes for millions of Americans. Sadly, for almost 15 years, the Republican Party has waged an all-out war on the ACA and the landmark consumer protections it has enshrined into law for millions of working people in this country. These include protections for more than 130 million Americans with pre-existing conditions, requiring coverage of contraceptives, prohibiting charging women higher premiums than men for the same coverage, and so much more. And in April of this year, 62% of the public had a favorable opinion of the ACA, and these protections are critical to my constituents, and frankly, they are critical to my family. I have a daughter who has a serious pre-existing condition, a chronic illness that thankfully is successfully treated with a biologic that would cost her $23,000 every month, if not for the protections of the ACA. And so I am grateful that we passed the IRA, which will finally allow our government to negotiate with over some of the most expensive prescription drugs available. And I am also astonished that the Republicans continue to push for the repeal of the ACA. In fact, Project 2025, Trump's Project 2025, lays out a plan for undermining and destroying the ACA. Project 2025 has a detailed plan from a right-wing think tank for the next Republican administration. And Mr. Wright, let me ask you about this. One of the key policies of Project 2025 is to separate the subsidized ACA insurance market from the non-subsidized insurance market. Can you explain what this would mean for Americans left out of the ACA's protections?
I think the things that we would be concerned about is the loss of consumer protections and ultimately coverage for millions of Americans who depend on that coverage. That would have losing those protections, and for some would be a problem. Losing the coverage would also have a destabilizing impact on the overall market, because those who are no longer covered would be left in a smaller and sicker risk pool, and thus have ever increasing premiums as a result. But the loss of consumer protections would be broader than that, and that would be the concern, whether it's access to basic essential health benefits or, as you mentioned, issues with regard to being able to get the care that you need regardless of pre-existing conditions.
So, for example, it could cause the loss of protections for people like my daughter who have a pre-existing condition, as do millions of Americans across that country. Is that correct?
That's correct.
Thank you. And overall, would this reduce Americans' health care costs or increase them?
As I mentioned, I think the destabilizing effect would not be just an impact on the people who would lose the subsidy or lose the coverage, but also have a broader impact on the system as a whole in terms of leaving people in a smaller and sicker risk pool with higher premiums.
So to put it plainly, it could increase health care costs overall. Is that correct?
Yes.
Project 2025 also calls for keeping anti-life benefits out of benefits plans, including coverage for abortion care, and I assume including coverage for contraception or birth control. And this is actually written in the plan, including costs for surrogacy. So, Mr. Wright, could you speak to the benefits that reproductive care coverage has had for Americans?
It's critical that people have the ability to plan and start families when and how they want them, but also to get the prenatal and postnatal care to have healthy babies and children and adults. This is critical, especially now that we have a maternal mortality crisis, and so those kinds of services are incredibly important to make sure that we deal with both disparities and the overall quality of care.
Thank you. I have more questions. I'll submit them in writing. Thank you very much.
Thank you.
Thank you. We'll now recognize Chairman Fox from North Carolina for 5 minutes.
Thank you, Mr. Chairman, and I want to thank our witnesses for being here today. This is a very important issue to the majority of people in this country, particularly those who are covered by employer-sponsored health care. Ms. Schuman, your written testimony highlights anti-competitive contracting terms such as all or nothing and anti-steering clauses, which prohibit a plan sponsor from contracting with a business associate's competitors or using providers outside of a business association's network. How do these restrictions affect plan benefit design and cost?
Well, thank you very much for that question. As large hospital systems have increasingly acquired other hospitals and physician practices, these healthcare systems dominate the market, and they use their market power to push out lower-priced, higher-quality competitors. And one of the ways that they can do that is through these anti-competitive contracting terms that they demand are included in contracts with group health plans, insurers, and third-party administrators. And these anti-competitive contracting terms come in several forms: anti-steering or anti-tiering provisions that prevent employers from utilizing value-based design to direct employees toward lower-cost, higher-quality providers, or all-or-nothing clauses, for example, that would require the health plan to contract with all affiliated facilities and providers, including lower quality ones. These contract provisions are designed to do one thing: to limit access to lower cost, higher quality care, and to tie the hands of employers in their efforts to promote more value-driven care. And that's why the Council is so strongly supportive of the Healthy Competition for Better Care Act that would restrict these anti-competitive provisions and urges the committee to approve it. Thank you.
Thank you very much. You just answered my second question. Ms. Wade, the Affordable Care Act does not require employers with fewer than 50 employees to offer health coverage to their employees. And yet NFIB reports that many employers still choose to offer coverage. Can you discuss the benefits for small employers and their employees of offering employer-sponsored health benefits?
Certainly. So NFIB, we've surveyed our members periodically over the years, and with the tight labor market that they're experiencing now, but have been for years, the ability to offer health insurance as the primary benefit outside of wages is incredibly important to many of them in attracting talent and retaining current employees. So the availability, the affordability of this benefit, for them being able to have a large choice of benefit structures to offer their employees, is critical for them in those purposes of retaining talent and recruiting for open positions. So this is one of the main hurdles that they face in offering the benefit is cost. We survey our members and they tell us that in the next 5 to 10 years, most of them are very concerned about their ability to keep the affordability aspect of offering the benefit to their employees. And so they're concerned whether they're going to be able to offer the benefit going forward. They're concerned about their ability to compete for talent in their workforce.
Thank you. Dr. Froston, your written testimony states that ERISA's preemption of state law created an environment of national uniform standards for employee benefit plans and allows employers to continue to offer health benefits. What would health benefits look like today without ERISA?
It's a really interesting question. I think, if you go back before ERISA, employers offered coverage for business reasons, to be competitive in the labor force. Just about every large employer still does. Some small employers do. And if you ask the employers, the small employers that do so, they're doing so for business reasons, to be competitive in the labor market. They're concerned about employee health and their productivity. I don't know that if we didn't have ERISA, it would look any different than that. I think ERISA certainly enabled employers, perhaps large employers, to made it easier to offer benefits across state lines. But I still think they believe in the reasons why they offered benefits to begin with, which is to be competitive in the labor market and to invest in worker health.
Thank you very much. My time's expired. I yield back.
Thank you. Pursuant to the previous order, the chair declares the subcommittee in recess. Subject to call the chair, we will plan to reconvene promptly in 5 minutes at 11:25. Thank you. So the subcommittee stands in recess. Come to order following our recess, and we'll now recognize Ms. Hayes from Connecticut for 5 minutes.
Thank you. And thank you to our witnesses for being here today. I also want to just thank my colleague, Ms. Manning, who left, for bringing up the idea about the ethics separation on committee. I was in the back and saw how this committee opened, and that's not the way we should be doing our work. And she brought up the ethics guidelines, which I think would be a real issue, except that the people of Virginia's 5th have already worked that out for us. While hardworking American people are struggling to afford medications, drug companies are reporting billions in profits. According to Protect Our Care, in the first 3 months of 2024, 15 of the biggest drug companies reported nearly $173 billion in revenue and nearly $29 billion in net profits. In 2022, I voted to pass the Inflation Reduction Act, which empowered Medicare for the first time in history to negotiate lower drug prices for millions of seniors. The 10 drugs selected for the first round of negotiations accounted for over $55 billion in total Part D gross prescription drug costs in 2023. These negotiations resulted in a reduction of 38 to 79% on the selected drugs. Mr. Wright, in Project 2025, and what we've heard from many Republicans on this committee, there have been calls for repealing the Medicare drug price negotiation program. What consequences will seniors face if the Inflation Reduction Act, if that portion of the Inflation Reduction Act is repealed?
Thank you for the question. I think there will be impacts to both the individual beneficiaries and to the program as a whole. Individual beneficiaries are getting the benefits in the Inflation Reduction Act of an overall cap on prescription drugs of $2,000, access to free vaccines, the cap on $35 for insulin. But more, they're getting the benefit of getting the negotiated discount rate when they go to the pharmacy, especially if they're insured. If that was to be repealed, those benefits those direct-to-consumer benefits would go away, but also would be the savings to the Medicare program and would have a problematic impact on the solvency of Medicare and the trust fund.
Thank you. And we're seeing that even with these negotiations, these companies are still putting up record profits. House Democrats are looking to expand the drug pricing negotiation program to private healthcare markets like those covered under ERISA. Could you explain how applying the prices secured through the Medicare drug price negotiation program will reduce costs for millions of Americans with private health insurers?
To the extent that the Medicare and the government is using its purchasing power to negotiate discounts, it makes sense that those discounts should be applied to the broader public, whether through, including in the commercial market. That would help bring down the premiums that payers pay, whether employers, union trusts, or individuals who pay out of pocket for premiums.
Will this also have a benefit on the employer?
As I said, that it would be, since the employer is often the one that's paying the main premium, often with a share of cost by the worker, it would have a benefit for both the employer and also the worker, whether as a share of premium or as the ability to have those wage increases in other ways.
So both the employer and the employees would benefit from negotiated drug prices and lowering the cost of prescription drugs. Thank you so much for being here.
Thank you.
The Inflation Reduction Act dramatically lowers costs by requiring drug companies to provide rebates when they raise list prices faster than inflation limits. Limits total out-of-pocket costs through Medicare Part D at $2,000 annually and caps insulin costs at $35 per month. But it is imperative that we pass legislation that would expand the drug price negotiation program and the inflation rebate savings to ensure that individuals with private health coverage also benefit. Can you just speak in my last 40 seconds about how we're talking a lot about Medicare Part D and people who participate in these programs would benefit? How would this expand to everyone that would benefit from this type of work?
I think the more we can do to expand these benefits broader than the Medicare program, that would be a direct benefit to consumers at the pharmacy. This is one of those monthly costs people feel every time they go to the pharmacy, but also even for folks who don't use prescriptions because it contributes to the premiums everybody pays.
Thank you. And as we are talking about rising inflation and the cost of living, the amount that families are paying should be considered as we are thinking about these things. And this is something that will definitely help. Thank you so much. I yield back.
Thank you. We'll now recognize Mr. Burleson from Missouri for 5 minutes.
Thank you, Mr. Chairman. Dr. Froston, in your written testimony, you said that small employers have been responsible for the decline in the number of employers that are offering health benefits. What has happened to cause that to occur? What steps can we take so that small employers are wanting to offer those health benefits?
Yeah, keep in mind that small employers were never as likely to offer health benefits as large employers, and there's clearly an affordability issue there.
And it's just a complexity part of being a small business, right?
I think the complexity part comes in because a small business, you don't have as many people that you could delegate these responsibilities to. You could certainly hire a broker to help you navigate the health insurance part of it, but that's just one more piece when you're potentially starting a business.
Right.
I think the challenge with small businesses is that we've done surveys, they're dated, right, about 20 years ago, where we asked small businesses that didn't offer coverage why, and whether they thought it had a negative impact on their business. And for the most part, they didn't. So if you can't convince them, and the NFIB has asked a similar question like that recently, if you can't convince these businesses that not offering it has a negative impact, I think it's going to be very tough to convince them to offer it, even if premiums were more affordable. They're just not focused on it.
I had a whole list of questions. I'm going to kind of go I'm going to wax philosophically here, if that's okay.
Mm-hmm.
So I'm reflecting on the fact that in America at one point employers created pensions, right? And they managed those pensions, and over time, decades, they became unsustainable. They became a liability. There was a lot of uncertainty with those, and sometimes you'd have people that would lose out because their employer might go belly up, and now their pension is gone. And so the result was this institution created a tax incentive for individuals, or created a mechanism so that employers can offer IRAs, can offer 401ks that put the money in the hands of the individual, let them choose where their investments are going, let them choose that. Could something like that be done with health insurance, where the federal government is giving the same tax benefits, but encouraging the employer to provide a benefit that the employee then takes control of? You
could do that now under existing rules with ERISA, individual coverage health reimbursement arrangements. Employers can give workers money on a tax-free basis and let them go buy insurance on their own. It's not a very popular benefit. I think at most, there's different estimates on how many people are in such an arrangement. They're all small, right? Maybe
it's not. I've not heard of it. It's very underutilized.
Maybe 1 million people are in such an arrangement, but I don't think we know exactly. I've seen numbers of 200,000, maybe 400,000. You add independents, you could double that number. So that's where the 1 million estimate comes from. We've asked large employers about it. Some of them we've asked about it to see if this is something they'd be interested in. Didn't even know about it. I think the NFIB survey asked about it as well, and there was a lack of familiarity there. I don't remember the specific numbers.
Mm-hmm. Being a former state legislator, I saw firsthand how a lot of employers were happy to move to an ERISA plan and to escape all of the state regulations, the health, the mandates on what they have to provide care for. And I can only imagine how difficult that would be to go if you were occupying or had employees in multiple states. Let me ask this: what else can we do, for example, to ramp up that individual program for small business owners? I know that we've got the association opportunities as well. Is there anything else that you can see?
I'm not I don't know to what degree small business, you got two kinds of small businesses, those that offer coverage, those that don't. I don't know that those that offer coverage are going to go in that direction, but they're already committed to offering coverage. And while you've seen some erosion, it hasn't been a very large erosion. I think this would be more appealing to employers, small employers that didn't offer coverage, as a way just to give their employees some tax-free benefit.
Has Mrs. Schuman, has these associated plans, these plans, where you're grouping people based on association, have they experienced any savings?
Well, our member companies are primarily, large multi-state employers that provide comprehensive health care coverage to their employees. So it's just not.
This may be a question that Mrs. Wade can answer.
Yeah, I think.
The gentleman's time has expired.
Certainly.
If she could answer.
Let her submit that for the record, if she would like. Thank you. I apologize. All right. Now recognize Ms. Wild from Pennsylvania for 5 minutes.
Thank you. Mr. Wright, I have a particular interest and concern about the role of private equity in healthcare, and I do see in your written testimony that you mention the role of private equity in healthcare, and I want your opinion on a couple of things in a minute, but just for the benefit of people who might not understand what private equity is, and tell me if I'm incorrect about anything that I say. Basically, this is private investors who contribute capital, but they leverage their investment with a whole lot of debt. And in the case of healthcare, they may use, and likely do use, physical assets, whether it's hospitals, buildings, or whatever, as collateral for that debt. And of course, then they have to pay off the debt, which to my lay mind means they probably have to generate a whole lot of revenue in order to keep up with payment of that debt. Have I stated it correctly so far?
Yes.
Okay, thank you. And I've read that private equity has invested nearly $1 trillion in the healthcare system in the United States since 2006. That means private equity collectively. And would it be a fair statement that when a consumer, a patient, goes to a healthcare provider, goes to a hospital, that chances are they don't know much about the ownership structure of the hospital or the healthcare place?
That is a fair statement.
Okay. It's not like there's a big plaque on the side that says owned by private equity investors, so and so and so and so. Okay. And there's been a number of studies, including one by Harvard Medical School, about the fact that private equity actually results in higher prices to consumers, that more profitable services are often performed that don't match either the need for them or the benefit that they can convey, surprise medical bills. And then one study, the Harvard one in particular, found significantly worse outcomes for patients, particularly Medicare patients, in private equity locations. So my question to you, after all that, is what can Congress do to manage this problematic role of private equity in our healthcare system?
Thank you for the question. I think there's a number of things that Congress can do. It is an issue of concern. We have seen a lot of money come in from private equity. It has certain incentives that are not necessarily aligned with community health and more for short-term profit, even in some cases stripping the assets of institutions to get the most value, or at least short-term value from them. I think there needs to be some transparency in this regard, just to even know when these transactions are happening. It's been actually surprising how quickly these ownership relationships have changed, even in the last 5-10 years, whether it's to medical groups or in certain parts of our health system. And so having greater transparency of ownership, particularly with private equity, would be important, and also oversight over the actual transactions themselves, whether by the FTC, the DOJ. I know states are introducing laws to have oversight by state attorney generals. Multiple states had bills this year. I believe one is on the California governor's desk. And I think it's a concern because the growing body of literature is that private equity is associated with higher the growth and ownership of private equity associated with higher costs and, in fact, lower quality and even closures, depending on the business model.
So my understanding is that so far at least, it's a relatively small percentage of healthcare systems in the United States that are owned by private equity. But would it be fair to say that struggling hospitals, for instance, in smaller communities might be more susceptible to a private equity buyout or takeover?
I think that's certainly true, and it's becoming a big percentage in certain pockets of our system where those investors are seeing the opportunity to extract more dollars out of our health system.
Can you elaborate on that? What do you mean?
Whether it's on ambulances, whether it's in certain specialties, whether it's in certain areas.
Okay.
So, like, if you look at it overall, it's a really small percentage, but in certain markets, certain areas.
So you weren't talking about geographic areas, you were talking about areas of medicine or services provided. And one of the things I read was that the higher risk, more specialized areas of medicine are more susceptible to private equity takeovers.
That's right.
Is that fair to say? Thank you. I think it's a huge problem. I hope that we can address it in the coming years in Congress. And I think that it's a problem that's going to continue to grow unless we rein it in. Thank you for your information.
Thank you.
I yield back.
Thank you. Recognize now Mr. Bean from Florida for 5 minutes.
Thank you very much, Mr. Chairman. Good morning to you, and good morning, Help Committee. What an honor to be here, and to our distinguished panelists. It's great to see you. Since the COVID pandemic, the rise of telehealth has taken America by storm, and it's a popular option for many, many Americans. And there's a convenience factor, it's all kind of things. But now we are seeing that it's not as affordable as you would think. It would think this with innovation and with the efficiency of telehealth, it would be a much less expensive option. One of the problems is different fees that providers and facilities are putting on telehealth visits to make it just not as affordable as it could be. Ms. Schuman, you have mentioned it in your testimony. I want you to talk about it. Is it a problem? I'm considering, this is just between you and I'm considering doing a bill to limit fees and add-ons, which sometimes Americans are confused. And I would be confused if you get a bill from a doctor, but then get a bill from a hospital, and then get a bill from somebody else facilitating it. Is it a problem? What do you think it is? Is there a need to fix? What say you, Ms. Schuman?
I say that it is a problem and that it needs a fix. Allowing hospitals to charge a facility fee for telehealth appointments is a prime example of a payment distortion that's increasing healthcare costs for employers and patients. But these services are delivered via telehealth, but the facility is a phantom, but the fee is very real. We strongly support legislation that would protect group health plans from having to pay facility fees for telehealth services. It just doesn't make sense to pay a facility fee, a hospital facility fee, when the facility involved is basically an internet connection. And voters see through this too. By an overwhelming margin of 82% to 9%, 8-1, voters believe the patient should not be charged a hospital facility.
Ms. Schuman, it sounds like that if you were a member and I presented you would vote yes. Is that correct?
That is correct.
Fantastic. So, and you think it's worthwhile to do this bill?
Absolutely.
Fantastic. All right, I'm very close to launching this bill. Ms. Wade, NFIB is the forefront. It's the freedom-loving businesses that want to get government out of the way and just provide a service, make money, and be the backbone of small business. I did a roundtable. I partnered over the break with the Clay County. If they're listening, thank you. The city of Orange Park gave us their facilities. It was town hall. We partnered with the Clay County Chamber of Commerce. They invited just a handful of variety of businesses, and I sat there and listened to obstacle after obstacle, challenge, inflation, taxes, hiring practices, regulation, and we talked a little bit about healthcare. And many of these small businesses are just, they're challenged by the immense costs of offering health plans. What's What say you, Ms. Wade and NFIB? What do we need to do to make healthcare more affordable in America? I know it's a big question, and welcome to the world we live in. It's such a little tight window, but is there a 50,000-foot view of what we need to do to get healthcare more affordable in America?
Sure. So not surprisingly, our studies find, similar to what you heard in the roundtable, that 41% say it is a critical issue in operating their business, the cost of health insurance, in their ability to afford it themselves as the owner, but also in offering it to their employees, or potentially offering it to their employees if they don't offer it already. Transparency, better design choices, more plans available to small business owners will help in having stabilized and lower costs for them to offer the benefit. Association health plans, expanding those opportunities.
So it sounds like you're saying, if I can summarize it, choice and competition, that's what the American consumer and small businesses want. How devastating if we went to a one-size-fits-all single-payer system, how devastating would that be to Americans and small businesses?
Small business owners would be less able to compete for talent in retaining current employees and attracting applicants for those positions if not given a choice to offer the benefit.
You nailed it. Devastating is what you're saying. It would be devastating to have single payer. That would eliminate single plans, health plans, and wreak havoc across America. Thank you so much. Mr. Chairman, I yield back.
Thank you. We'll now recognize Mr. Scott from Virginia for 5 minutes.
Thank you, Mr. Chairman. Mr. Wright, we've heard a lot about association health plans. It's always seemed to me that if you get a group of lower cost, healthier people and make an association out of it, the association might save a little bit, but everybody left behind ends up paying more. Is there any evidence that eroding consumer protections, promoting association health plans actually lowers healthcare prices in general rather than shifts them to somebody else?
I think a lot of the savings comes from the fact that they don't have to abide by certain consumer protections and patient protections, which is a detriment obviously to the workers or employees, and also this issue of a risk shift, where if you're skimming off the healthiest populations, then you're shifting those costs onto the broader market for small businesses and having an impact of increased premiums there. I also just want to make sure that with regard to association health plans, that there is strong financial oversight, because you don't want to have a situation of financial fraud or issues where, because of lack of due diligence, people are left high and dry without health care because the money went someplace else.
You're talking about solvency of these plans? Yeah. What happens when they go broke?
Well, then that's a huge disruption both to the health care for the workers, but also for the employer, issues of liability, issues of great concern. It's not good for anybody.
And what kind of, you talked about consumer protections before and mentioned the protection if you have a pre-existing condition. What other kinds of consumer protections would you lose if you get into an association plan?
Some of the consumer protections are just whether certain basic benefits are covered, whether it's preventive care, whether prescription drugs, equipment and services, etc.
The American Rescue Plan Act and Inflation Reduction Act improved tax credits, Mr. Wright, and particularly for those earning over 400% of poverty, where there was a cliff and you got no benefits. Now you get benefits, just pay a percentage of your income. At some point in the income scale, you'll meet the sticker price. So you wouldn't be entitled to anything, but how have the premium tax credits helped both low and middle income individuals?
They've been a lifesaver and a lifeline for millions of Americans. Over 5 million more Americans are covered, in part due to the enhanced tax credits that have been put in place in the last several years. People have gotten reduced costs at a time when people are screaming about affordability and have been screaming about healthcare affordability for decades. This is a direct form of assistance that says you do not have to pay more than a certain percentage of your income for coverage. And you're right, those folks just over 400%. For those under, they had the guarantee that they didn't have to pay 8.5% of their income on coverage. But just those over, especially if they were older, would be paying 20, 30% of their income on coverage, having a huge impact on their ability to make ends meet for other needs. So it's incredibly important that those tax credits get extended because they run out next year, and that needs to be done sooner rather than later in order for them to take effect in 2026.
Now, for small businesses where the owner may be just over the threshold, association plans started to look like a nice alternative. How does the elimination of the cliff affect the attractiveness of association health plans?
In fact, if I had a chance to respond to the representative here, I think the ACA marketplaces, and especially these enhanced tax credits, provide a real benefit for small business. So, a lot of the people in these marketplaces are solo entrepreneurs, real estate agents, contractors, and people who are starting family businesses who are in the exchanges and marketplaces right now and getting this benefit. But if these tax credits are not extended, that would be a premium spike of literally hundreds of dollars, and in many cases thousands of dollars to their bill. It would also have the impact of meaning that some of those 5 million people that got coverage would lose coverage and then have an impact on premiums overall in the overall marketplace.
Now, if you're in an association plan, you're not getting a tax credit, right?
No.
And so the association plan would be competing with an ACA plan with a tax credit.
That's right.
And that makes it virtually impossible for association plans to compete.
I think that at this moment, the ACA marketplace is a much better deal for people up and down the income spectrum.
Thank you, Mr. Chairman.
Thank you. We'll now recognize the Ranking Member DeSaulnier for 5 minutes.
Thank you, Mr. Chairman. Last spring, the New York Times published the results of an investigation into Multiplan, a private equity-backed data analytics company that works with many employer-sponsored health plans and their third-party administrators, or TPAs. The investigation found that when Multiplan lowered reimbursements to providers, consumers would be on the hook for exorbitant balance bills, and employers were liable for huge fees. In many cases, the fees paid to Multiplan and the TPAs were more than reimbursements being paid to healthcare providers. To me, this is a clear example of the inefficiencies and unethical behavior plaguing our healthcare system. Mr. Wright, you any comment on Multiplan and its inefficiencies for consumers?
Yes, thank you for the question. I think we're deeply concerned about the potential price fixing and anti-competitive behavior. I wish I could say I was shocked, but this is the kind of scheme that we've seen in the healthcare system, with corporations trying to take a profit, often to shift costs onto consumers. We're particularly concerned about the issue of a proprietary algorithm that is not public, that is making these decisions, and the issue of the shifting of costs onto consumers through balanced billing. And so we do support the call for investigations by you and others in the House and in the Senate to look into this and deal with it as appropriately.
Ms. Schuman, much like PBA's, the inefficiencies of the system.
Okay. Well, thank you so much, and I think this just brings the light to the need to bring more light to healthcare system and the need for transparency, to shine a light on these kind of payment distortions and practices that are driving higher costs for employers and also for working families. And again, the important work that the committee has already done to advance those transparency requirements in the Lower Cost, More Transparency Act.
Thank you. The last hearing we had on ERISA, we heard testimony about claim denials. Many of us have experienced at least one instance of a denied claim. We all know that claim denials can impose serious health and financial hardships. During our last hearing, the Democratic witness recounted the tragic death of Kyrie, a 27-year-old flight attendant who was denied prior authorization for a heart transplant over criterion that never existed in the plan's documents. The denial would eventually be reversed, but the decision came almost a month after Kyrie's death. Despite stories like Kyrie's, we don't even collect adequate data to help us understand the extent of the problem. The Affordable Care Act required the Department of Labor to issue regulations to require group health plan reporting on claim denials, and in 2016, the department proposed to do just that. Unfortunately, the Trump administration ignored the ACA requirement and pulled the proposal in 2017. Mr. Wright, at least anecdotally, I'm hearing the problem is getting worse from providers, that claims that they regularly put in to providers are being denied, and either they or their clients give up. Do you have any comments about claim denials and the possible effect of companies like MultiPlan?
Thank you for the question. Claim denials is a big issue for both patients and providers who are trying to provide care to their patients. You don't want a plan or an employer to be judge, jury, and executioner. You want independent review. You want ability to appeal if your care was denied that was medically necessary. And right now, the relief under ERISA is very limited. And so I think we need to look into this. And right now, we basically even just need the transparency to even know why claim denials are happening. Because right now, we don't even have that. We need to be able to know just the timeliness of these claims, how many claims are filed, what's the rate of denial, and for what reasons. And then I do think we need to have a greater look at what kind of relief can be provided under ERISA.
Ms. Schuman, claim denials.
Yes, well, certainly I couldn't agree more about the need to have more transparency again for these claim denials. I will say, that there's an important service that appropriate medical management and prior authorization plays, without a doubt. But again, I think the need for greater transparency to understand where those distortions are.
Thank you. Yield back.
Thank you. I'll now recognize myself for 5 minutes. Dr. Froston, President Biden and VP Harris have tried to expand even further government's role in health care, including, as we saw in the video, Medicare for all and lowering the age to qualify for Medicare. But as government control of health care expands, like when Democrats increase subsidies for Obamacare plans, what happens to employer-sponsored health insurance?
Yeah, we've talked to large employers about expanded subsidies, and for the most part, it doesn't affect what they do. They are concerned about recruitment and retention. They recognize that their employees value health benefits more than any other benefit, something I remind my retirement colleagues of all the time at EBRI. Small employers, we haven't polled them on how subsidies might affect their behavior. But I would point out, to the degree offer rates have eroded in the small group market, that was happening before the ACA passed. So I think its premiums are driving that more so. And the ones that continue to offer coverage are doing so, I think, because of business reasons. They're concerned about recruitment and retention, and even with enhanced subsidies, they're still going to be concerned about recruitment and retention.
No question about it. The CBO report estimates 3.5 million people would leave employment-based coverage if Democrats are successful in permanently expanding eligibility for enhanced Obamacare subsidies. Why do you think government wants to move more people? From a quality private health care plan to a more expensive one fully paid for by the taxpayer? Why would government want to do that?
They're different markets, and they serve different purposes. The employment-based market is, those are groups that are formed for reasons other than the provision of health insurance. They're considered a natural group. And the non-group market, it's different, right? It's people that can't get coverage through their job, maybe they're in between jobs. The subsidies are much higher in that market. I think they're temporary because of people moving in and out. I don't know that one, certainly one system has an advantage over the other, but there are purposes that they both serve.
Ms. Wade, more small businesses would like to offer health insurance to their employees. but many can't afford it due to the costs of paying for the benefits, the reporting requirements, the bureaucratic burden of offering employer-sponsored plans. So how can Congress make it easier for more small businesses to manage this bureaucracy that comes with operating a health care plan?
For small businesses, 16% are in the self-insured market, so protecting ERISA and allowing them to still have the flexibility and affordability of offering those sorts of plans to their employees is hugely important, but also expanding the marketplace for the fully insured market in offering association health plans, those sorts of tools that they can use to better access affordable plans that they can offer their employees. They're competing with larger businesses for talent that are better able to afford these benefits, and the labor market is still quite difficult for them and a challenge in recruiting and retaining talent at their business. So because health insurance is the primary benefit that they're offering or would like to offer, having that marketplace be affordable and flexible for them is important.
Glad you mentioned it. I introduced and this committee passed the Self-Insurance Protection Act, which prevents federal regulators from redefining and regulating stop-loss insurance like it's traditional health insurance. Many employers, as you know, choose to self-insure, and they purchase this stop-loss insurance to protect themselves from the catastrophic claims. Why would some want to make it more difficult, some on the other side, for businesses to obtain stop-loss insurance, unless it's just to prevent them from being able to provide private insurance?
Without having that ability for those small business owners in the self-insured marketplace, it would be catastrophic for them in being able to offer the benefit to their employees and mitigating the catastrophic risk that they might incur with high costs associated with it. So protecting stop-loss insurance, making it widely available to small businesses is crucial in keeping that marketplace available to them.
Very good. Well, thank you, Mr. Owens. All right, we're going to go to Ranking Member DeSaulnier for his closing remarks.
Thank you, Mr. Chairman. Thank you to all the witnesses. I appreciate you being here. First, a comment just on this idea that universal health care versus a complete free market. I think what the Congress has tried to do over the years is balance, is to create an avenue for the private sector and employers. As a former employer who provided health care for my employees, and some of the struggles we had when employees actually needed to use that and how confused they were about their copays. I can remember instances where employees were crying because they couldn't afford their copays and never understood the documentation. So this balance between the private sector and creating employer-employee good relationship. NFIB, I was once a member when I was a small business owner. Having that balance of a good, responsible employer to good, valued employees. Healthcare benefits are really important. Healthcare benefits that are easy for the employer and the employee to understand and require value. Good quality of care. Too much of this hearing has been about cost, cost, cost. Cost is only important if you get value in exchange for the cost. So this idea, Mr. Chairman, with all due respect, that it's one way or the other just is not the American model. It's a balance, and I grant you there are some people who would like to switch that balance on both sides. Preemption is important when it's a national issue, but there are states' issues. There's another interesting debate today. Take the other side of states' rights, I guess, in this instance, which I don't regularly do, but maybe from California, as a member of Congress, I've become more of a states' right person than I was before, Mr. Wright, because I knew you when we both worked in Sacramento. So this balance is important. I don't think it's a choice of either or. And then lastly, on universal health care, we already have a universal health care system in this country. It's just really bad. If you call 911, the ambulance will show up. If you go to the emergency room, you will get care. It's called indigent care. In basic adult care, it's required under law. It's just that it doesn't pay. So the idea that somehow this free market is the heaven on earth that we could get just isn't reality. And if we had an efficient delivery of healthcare system that had high quality of care, both in the employer-employee market and also Medicare and Medicaid, people would live longer lives in this country. We would have a lower GDP ratio for health care, and we would have a better system. Maybe not perfect, but certainly better than it is right now. ERISA was enacted with the goal of protecting workers and their families. Given the dramatic changes since 1974, when ERISA was enacted, it's clearly evident that ERISA must evolve to effectively address new challenges and opportunities and improve the efficiency of our healthcare system. House Democrats' primary goal is to support and build our middle class from the bottom up and the middle out. This involves not only addressing the immediate needs of workers and their families, but also creating an environment where middle class prosperity can thrive and small businesses are part of that middle class. Ensuring that ERISA has strong consumer protections reduces waste, inefficiencies, and excessive costs, and enhances transparency in this critical efforts. Congressional Democrats are committed to fighting for working families, and we've made significant strides through recent legislative achievements to do just that, including passing the Affordable Care Act, the American Plan Rescue Act, and fighting the attempts by our Republican colleagues to overturn the Affordable Care Act, multiple attempts, including protections for consumers for pre-existing conditions. The Inflation Reduction Act, these historic pieces of legislation, all of them have increased coverage, protected consumers from nefarious practices, and lowered costs for millions of working families and seniors. Notably, the Inflation Reduction Act capped out-of-pocket drug costs at $2,000 a year for Medicare, capped insulin costs at $35 a month for seniors, and secured significant price reductions through drug price negotiations. The negotiations alone will save an estimated $1.5 billion for nearly 9 million seniors. But we must remain vigilant against proposals like those in the Republicans' 2025 that seek to roll back these critical reforms and eliminate the protections in the Affordable Care Act. Our work is far from finished. We must continue to build on these successes and focus on creating a fairer, more efficient system that benefits all workers, families, and businesses. Thank you, and I yield back.
Thank you, and I recognize myself for a closing statement. It was interesting to hear the minority member's reaction to the video we saw today with the unedited words of Vice President Harris without commentary, presented by none other than CNN and the Washington Post. I guess this is because she's been trying to express different positions over the past few weeks than she has expressed over her entire career prior to that time. As noted last week by none other than Bernie Sanders, whose Medicare for All bill she co-sponsored. Democrats seem to know that Americans don't support their actual positions, whether it's open borders, non-citizens voting, electric vehicle mandates, appliance prohibitions, anti-police policies, pro-criminal policies, higher taxes, more spending, and control by government, and yes, government-mandated, government-provided health care. This is a policy discussion, and the video revealed the Vice President's policy statements relative to the topic at hand. The American healthcare system is far from perfect, but most Americans prefer their private health insurance offered by their employer. So naturally, Democrats don't want Americans to know that they want to eliminate that. On behalf of the 153 million Americans whose health care benefits rely on ERISA, I think we've learned a lot today. Government, especially the Biden-Harris administration, continues to burden employer-sponsored health insurance through over-regulation. Meanwhile, they prop up the expensive Obamacare plans and daydream about single-payer Medicare for all. Government should actually, though, decrease intervention in the healthcare markets, not increase it. Americans want flexible, innovative healthcare, not one-size-fits-all. Employers have a strong incentive to keep healthcare costs low to help their own bottom line, and they have an incentive to offer good benefits to keep their workers. Democrats never seem to understand that. For 50 years, ERISA has provided the guardrails to protect individuals while allowing employers to develop robust benefit plans. We can amend ERISA while protecting it, because in doing so, we defend private insurance and shield Americans from devolving into a single-payer system. So we thank the witnesses today for your time and testimony. And without objection, there being no further business, this subcommittee stands adjourned.